Okay, so we're going to go ahead and get started. I want to honor everyone's time, not to mention we have a jam-packed agenda for today, so I want to use the entire time. So good morning. How's everybody feeling? So welcome to the National Churchill Library. Many of you mentioned this is your first time in this space. So don't you just love it? Yes. Okay, so I know basically everyone here, maybe except for like two people, maybe one person. I don't think I know you. But for the sake of formality, my name is Miranda Ward, and I'm an assistant professor here at the George Washington School of Medicine and Health Sciences in the Department of Clinical Research and Leadership. And I know we also have a virtual audience joining us, so I just wanted to make sure you know who I am. And I also just want to say how delighted I am that you have decided to join us for the final lecture in the GW Health Sciences 5-part Health Equity Professional Development Learning Series. So yes, we do have one more event in this series at the top of the year, and at the end of today's presentation, I'll tell you more about that. But yes, this is the final lecture, and all of the lectures are live stream. So like I said, we have a virtual audience tuning in right now. They're also recorded because we're trying to ensure that they're accessible, and they're all archived on our website. And so because we are recording it and we do have a live audience, bear with us today because, you know, today's discussion on how to talk about race, power, and privilege lends itself naturally to a discussion, right? And because we do have that virtual audience, for those of you that are on WebEx, definitely use the chat feature. You can also raise your hand. There's a raise your hand button, and you can pose your question, and we'll be sure. I actually have a mic, and I'll walk around and make sure that you can pose your question in the mic so that everyone can actually hear what you're saying and be actively engaged. So with that, I will move in. Well, let's see, the slides aren't working. All right. All right. So I need to get to the next slide and see how I get to the next slide. All right, perfect. Okay. So all of the events in this series, they have their own set of measurable objectives, right? And it almost seems as if they're standalone events, and they probably could stand alone, but when you actually combine all of the events in the series, they actually lend nicely to these overarching aims, which is really to recognize that, you know, there are many threats to advancing health equity, and we need to name them as such, and then being able to recognize what they are so we can identify solutions. And also recognize that there are some requisite skills and knowledge that actually come with being able to move the needle towards health equity. So this series definitely was designed to build our internal capacity, right? As practitioners, as researchers, as faculty. And so that's why the series was designed with that in mind. And finally, recognizing that this work can't happen alone. So you definitely need to work across sectors, across disciplines, in teams, and we've done that. We've actually modeled that. When I say we, GW Health Sciences. So we have partnered with the Institute for Public Health Innovation, which is our official partner on this series, and they have been really helpful in actually doing a lot of community health worker trainings. And so we really wanted to partner with someone who's very community engaged in that way. And so the Department of Clinical Research and Leadership is the official sponsor of this event. And so I just want to publicly recognize my chair, Leslie Davison, for making that a reality. And so as you know, this series does offer continuing education credits. And as we close out, I'll talk a little bit more about how to get those credits for you, if should that be of interest. So, like I said, you can't do anything alone. And so we actually were able to secure an external review committee that was comprised of several public health professionals to really allow for us to kind of think about, you know, what are some key topics we should probably explore in this series, and what are some speakers that we can bring on board to do just that. So I did want to recognize them. So without further ado, I'm going to introduce our speakers of the hour. So we actually have a dynamic duo. Yes, yes. So to actually lead us through our discussion. So we actually have Dr. Howard Straker, who is a PA. And he actually is an assistant professor in the PA Studies department here at GW. And he also is the president of the PA Educational Association. And he has a dual appointment in the Milken School of Public Health. And so it makes sense that he also serves as the director of that dual degree program, PA and PH. And he's joined by Dr. Susan Layla Shore, who's also one of my personal mentors. And so she is a practicing clinician as a PA, and she works at Whitman Walker Health, and she is a distinguished fellow in the American Academy of Physician Assistants. Yes, yes. And so, and she also is a full professor here in the PA program. So with that, please join me in welcoming our speakers that are going to lead us in our discussion on how to talk about race, power, and privilege.
So we're going to try and make this work. We have a poll everywhere question in here, and the software may be a little funny, but this is how you're going to do it. And if people have phones in their pockets, pull them out and go ahead and either get online to Polev.com, and it's SLELA / that, or you can text those letters SLELA to 2233, and that'll come up on the slide when we get there.
So we don't have any disclosure. Well, we'll leave this up here to make sure everybody gets access to it. But I want to start from a little history. So in 1899, W.E.B. Du Bois published a book called The Philadelphia Negro. And in it, he was basically the first person in the country to describe health disparities, racial health disparities. He described them, and he attributed them to social advantage, or actually to the social conditions, as the cause of it. He went on in 1900 to make the famous quote, the problem of the 20th century is the problem of the color line. And as we can see, 130 years later, we are still dealing with health disparities. We are now making an effort to eliminate health disparities. But in order to talk about racial health disparities, you have to talk about race. And race has been an uncomfortable topic in the country. And if you're training, particularly in our mold, we're looking at it with the eyes of, School of Medicine and Health Sciences has part of its mission and vision to eliminate health disparities. And we have, in our mind, the focus is going to be in the classroom for health professionals, but a lot of this is applicable beyond just health professional training.
We won't spend too much time on this. These are major goals to talk about challenges that instructors have in discussing race, to introduce the guidelines around case presentations and racial inferences in those, and to acknowledge some of the difficulties that we have in talking about these issues in the classroom. All right, so you guys get to do this, and those of you online, just sit down with a piece of paper or something and write this down. In the next 2 minutes, write down a brief response to why do you teach about race in the classroom? Let me see if I can get it.
And if you don't teach, why would you want to?
Why would you
Why do you think
exactly? And then, and we're keeping you to the 2 minutes because we don't have that much time. If you have time, turn to your neighbor and talk about that. You turn to your neighbors, you can speak out loud. Okay, that was our 2 minutes. So I know I didn't really give you time to get going on that discussion. But does somebody have like one big point they want to raise around that? Why do you teach about this, or would you? Anyone? Yeah.
Is it on? It's on now.
Hi, my name is Rico. Because racial and ethnic minorities are historically underrepresented in academia, medicine, and research. And of course, this impacts the quality of services that they receive.
Okay. Okay.
And the
quality-
research, of course, too. Yeah.
Research and quality, yes. Anyone else? Big reasons.
Good morning, everyone. Grace Henry, Director of the Office of Diversity and Inclusion in School of Medicine and Health Sciences. I said lack of historical knowledge, realizing that many of our students are coming from backgrounds where they may not have firsthand experience of racial inequity, and it becomes something that's more of a concept instead of something that's realized. And I think there needs to be a historical foundation for them to understand the impact and the presence of racial disparities.
Leslie Davidson, in clinical research and leadership. I think that it's the historical perspective, but I think that what's happening currently is equally as salient to whatever we're teaching. And racial issues are really part of the fabric of society, and whether or not we teach in healthcare or in sociology or philosophy, without that understanding, there's a huge hole in that fabric that we're trying to build for our students.
Exactly. Just as Dr. Straker said initially, that history of W.E. Du Bois, you know, I didn't learn that in school. I had to read that much later in life. It was not taught in my curriculum anywhere along the way. And so that's something people don't know. And as you say, it stretches right into the present and will stretch into the future. And we all have an active role dealing with that. They're not moving.
So actually, that fed into our assumptions. I don't know why this isn't picking up. Hello, is it picking up now? Okay. Go back for a second. Okay, so we have some assumptions that we're operating with, and we just wanted to put that out there so everyone's clear on where we're coming from. One is that we believe that racism is embedded in the structures and the fabric of American society, and that through that being embedded in that structures, that informs a lot of how people respond and behave, and where they do things in relation to each other, and even inside and outside of institutions. And that included in that, because it's embedded, that racism, that the word is embedded, that for us, we think that there's either racism or anti-racism. If failure to address racism supports racism. So in our opinion, one of the reasons, our reason to teach about race and racism is because we're supporting anti-racist work. And I guess the other last piece of the assumption is that we see learning as learning can provoke anxiety, can be discomforting, but we also recognize that some of the best learning happens from discomfort. So we're okay with being discomforting and part of a learning process.
Speaking of discomfort, I tried to upload our poll everywhere, and I uploaded the wrong slide. We're a different talk, so we're not going there. Okay, so here are our assumptions: that racism exists and is pervasive and embedded in everything. That one's behavior either supports or refutes that. So everything we do, yeah. And that our reason to teach is because we have to be constantly doing that. All right, so this is the slide I don't think this is going to work because I was not able to log in this system. So I'm afraid the poll everywhere is not happening. Think for a second, what are some things that cause discomfort among teachers and students or learners around race? What are some things that you've noticed in the classroom when you're bring these things up or try to bring these things up, what happens? Guilt,
Yeah, someone said guilt.
Defensiveness.
defensiveness. So guilt and defensiveness go together. You feel guilty or unheard or vulnerable, and walls go up.
Risk, that it's risky for some people to either say what they feel or what they've experienced, not knowing what the responses may be to that. Sorry?
Dismissive.
Dismissiveness. Some people feel like their experiences get dismissed, their feelings, their experiences get dismissed. Others shut down.
So
Okay.
dismissed and shut
Shut
down.
down,
Those are related concepts. They're not the same, but they're very much related. Are we getting anything from the online? Ignorance, anger? Anger and resentment. So when that wall comes up, it's anger and resentment.
Confusion. Yeah.
Not knowing what's the right thing to say.
Understanding the terms that people are using. Disengagement, yeah, going back to either withdrawing or just like checking out. Yeah. So we have, okay. So one of the things that we found this, we thought this picture is kind of can show what could happen in some of these conversations. You have Franklin by himself, isolated, maybe disengaged, maybe, you know, some of those same words. Maybe some people are feeling guilt that he's by himself on the side of the table. But, you know, this is actually from, you know, Charlie Brown's Thanksgiving or something. And back when Schultz put Franklin into it, part of it was just trying to, you know, be more socially responsible. He made a black member of the Charlie Brown clan, but this is an interesting picture that kind of comes out.
And it's really interesting from the historical perspective. So like I was born in 55, so I was a child looking at this comic.
Right.
And think about what a little white girl versus what a little black boy was seeing, you know, in 1965 or whatever when this came out, right?
So we want to give some definitions, but we don't want to spend any time on it, partly because this series, we're the fourth part of this series, and the definitions have been given before. We just want to remind you that race is a social construct, and that racism is an act of omission or act of commission. You can either do it or not do anything about it. We'll support it if you're not trying to undo it.
Right. And then the ideas of privilege are often go unaddressed. A big aspect of what's going on with racial discussions and racism is privilege that is usually unrecognized by the people who own that privilege. The way I describe it to people is I can walk through and not even see a door where somebody else is having that door slammed in their face because of my whiteness. And that's the other piece of it is whiteness is just as important to this discussion as blackness or any other ness. You know, that you have to keep in mind that there's a whole cultural system around being white. And a lot of that has to do with that privilege.
So Glenn Singleton, in a book, and it's been updated over the years, called Courageous Conversations About Race. In it, he kind of outlines a bunch of things that would help have those discussions. It was really built for educators. Glenn Singleton is an educator, and it's really for educators, basically K through 12, to think about how to engage with race in their classrooms. So one thing when we talk about race is there are at least 4 dimensions in the discussion. There's the intellectual, which is about thinking. There's the moral, which is about believing and what people believe. There's the emotional, which is about feeling. And then there's the social, which is about acting. And there's probably more, but because there are all those dimensions and they don't always in a person line up together neatly, it becomes one of these uncomfortable things, especially when we're talking about emotions and morals. And so these guidelines for facilitators is really a way to kind of begin, he actually names them as conditions. We use them as guidelines, as ways to help forward that conversation. So the first 2 are really things that Singleton focuses on the facilitator to be familiar with. Be familiar with your own intimate experience about what race is and has been for you. And then isolated just to race. When we do this with classes or things, we try classes and students, we try to focus in on things that are concrete. So it's not just, we're just talking about race as this theoretical thing, but their examples are going to be more current, more local, and more real for them. Sometimes we use it through virtual narratives that are, so it's not about anybody in the rooms per se, but it is about other people's experience. And we try to keep the conversations focused on race, not on any of the others that it could be, not on sexual minorities, not on gender. When we have those discussions, we isolate those discussions about that. And so when we're talking about race, we want to talk about specifically about race. These other areas here, these two are really kind of focused on how to help sustain the conversation. So one is you want to normalize the conversation being that race is a social construction. So there are times that we have to bring it back when you start feeling like people are thinking it's a biological thing. We have to bring it back to normalizing the social construction of it. And that social construction is also a political construction, and it's also it's social at the same time. And that there are multiple perspectives that we acknowledge and we try to negotiate in the course of the conversation. Then these four here are kind of the guidelines that we want the group to agree with at the beginning. And that our job as facilitators then is to monitor those agreements and try to reinforce them occurring in the course of the conversation. So you want people to try to be engaged, and that means you too staying engaged. And you want to try to do it at all four of those dimensions: intellectually, emotionally, socially, and morally. And you want to make it okay for people to feel discomfort, to be vulnerable. The discomfort is really about being vulnerable. And I would say as a faculty member that, and probably it ages me, but there's a level of discomfort that a lot of times, particularly in healthcare, like people are going to healthcare because they want to be good clinicians and take care of people and know everything they need to know and do the right thing. And now we're asking them to be vulnerable about something that they're looking for a right answer. And there is no one right answer in this situation. And we want people to speak their truth, meaning be authentic for themselves, say what they think and what they feel. We try to help manage how they say it. But we want them to speak their truth and not other people's truth, not speak for other people, not what they think other people want, but to speak for themselves. And then we try to set the mood so people understand that this is not a one-shot deal. At the end of this conversation, it's not over. The conversation has to continue beyond the one-time deal, and to be comfortable with kind of engaging themselves with this conversation. So as a facilitator, you have to be clear what your working definition of race is so you can normalize it in the conversation. And then you also want to examine both for yourself, but also for the group. And like in most of our classes, most of the students are white. And so it's easier to talk about the pathologies of communities of color than it is to look internally at what whiteness means and what advantages and disadvantages and things that happen that occur without recognizing my role in this process. It takes, in this country, it takes people to be white and people to be of color in order for race and racism to occur.
Just one other thing about isolating race. It doesn't mean we don't ever connect the dots between the different intersectionalities and ism, but it means that when we're talking about it, that we have to hold that focus and not let people Okay. So the other issue that you'll hear is the idea of creating safe spaces and brave spaces. And initially, this came out of the idea of creating safe spaces for marginalized groups to be able to talk about their own issues. But it has transformed over time, and you see it now utilized often to protect kind of the majority viewpoint or group. So we have to keep both things in mind. We don't want to avoid these discussions by creating safe spaces, because if it's too safe, the issues are never going to come up. Safety precludes stepping out of your comfort zone, and that's where the brave spaces come in. So we need to be able to create in our classrooms both a safety in that people are not going to feel beat up, but also an ability for people to be able to allow that vulnerability and to be able to speak their own truth and be authentic. This is something that happens over time. We have a cohort program, so we have 65-ish students going through together, and they develop a family kind of tie with each other. That doesn't mean that they're necessarily able to be vulnerable towards each other at all times, but there's a little more ability to do that. And then, as Dr. Straker was saying, we can do that in online forums where we allow for some different kinds of.
We do that, you know, also recognizing 65 is not probably a good room to have an intimate conversation about race. So we utilize small groups, we utilize things online, and then we kind of figure out what are we going to talk about in the big group, and then what are we going to talk about in the smaller group.
How do we take those two things and utilize them together? And we'll give you some examples of that.
So one thing to also recognize, and also because the title had the word power in it, is to recognize the role of power. And you can't talk about race in this country without talking about power, because, you know, the society is hierarchical and that it deems certain positions to have certain power. So white has more power over communities of color. At least that's what we're challenging, but that is the way it is. And we want to think about power in the conversation in the group in terms of the verbal things that happen. And so make sure the conversation about race also talks about the dynamics of power that exist. But then we also want to think about the nonverbal power that exists and the nonverbal conversations about power. And that happens like we're the faculty, you're the student. So that's a level of differential that we have to think about. It's one thing, and one of the things that we have learned over time is the two of us kind of work together well in this process. When I first came to GW, which was about 20 years ago, there was a different set of student than is here now, but I was the angry Black man who was just talking about Black health disparities, and all I was doing was giving numbers, but that was what happened. So we decided that Susan would introduce race to our students first. Because it was safer in that kind of environment. So that was one of the things to recognize. Also, facilitators of color will tell you that their experiences a lot of times are undermined. The students don't feel like they're biased. If she'll talk about something that's racial experience, it's more objective than if I talk about it for some reason. But that is the kind of unverbal things that exist.
It's a privilege thing. I get to be objective.
And then we want to take it back to them thinking about their roles with patients and as future clinicians. And then we talked a little bit earlier, but silence in itself has a power, and sometimes we have to try to read into, are the students really thinking and turning it over, or are they just withdrawn from this process?
And you all know that sometimes silence in the classroom means they're walking out the door and then, so you got to think about that. Just a big concept to keep in mind here. Doing this work, you are going to get slammed on occasion. And so it's really important to be very, very comfortable with yourself, with your own, whatever color you are. I have to be really comfortable as a white person who is interested in these issues and working towards these issues, and sometimes being called on, you know, my privilege, and being okay with that if I'm going to teach this for students. Howard has to be really comfortable with his own Blackness and what that is and how he feels about those things in that interaction. And we have to be comfortable with each other if we're going to do this together.
So one of the things that we did when we first started was there's a book, and we have references at the back called Taking It Personally, which is written for some teachers out in California. It was a Black and white set of teachers who did their own personal reflections for themselves and then discussed it with each other. So that's what we did. We did our own reflections of our experiences of race and our feelings and thinkings, and then we had these conversations. And we found that to be very helpful because sometimes things come out of a thing that kind of hits a button, and that we, you know, because I'm kind of clear on where I'm coming from, Even if it's one of my buttons, I know it's one of my buttons and I can work with that in that process. Or she knows it's one of my buttons and maybe
And I
she
might
needs to
pick it up
take
and
over.
grab it and hold it for a minute until he has a moment to process, and so we do like that. And what it meant is so Howard and I were born a month apart in the same year. So we also have the same but very different historical experience, right? So we were in the same world at the same time in very different worlds. And so that has allowed us a lot of ability to work together in this way that I think is interesting. You may or may not find, you're never going to find Howard. Good luck on that. But look for those relationships. Where can you work with others?
So we're going to shift a little gear here. This in response to the students, and that's one thing about the students today have kind of shifted our conversations in the classroom. The students, I would say the students in medicine and health professions are ahead of where the faculty and the curriculum is a lot of times. And in response to students who were saying, we're seeing all these examples by folks who are teaching us that are stereotypical, that are promoting bias and are not really challenging racism that's embedded in medicine. The School of Medicine had a task force to look at the curriculum to try to make it, to deal with difference in a way that was more healthy than just promoting stereotypes and bias. And this is based on the work out of an article by Krishnan and others, including our own dean at School of Medicine and Health Sciences, Kathy Chrétien, in academic medicine. There's a platform, electronic platform that has cases that are designed at medical schools and PA programs and nurse practitioner programs are using for training. And the cases were embedded with stereotypes and bias. And so they convened a team of people with students and faculty, and then they did literature searches and they did a bunch of work, and they came up after analyzing the cases with a set of rules or guidelines to kind of look at how to promote cases. And from that work and from the task force here at the School of Medicine and Health Sciences, a set of guidelines were developed, and the link is here to those guidelines. And without going through all the guidelines are set up to expose students to various alternative looks at people of color. So for instance, I came up in medicine. In the last 30 years, medicine now uses racial identifiers in the top 3 words of presenting a patient. But before then, and also when you're not presenting a patient, the only patients that have races are the ones who aren't white, right? So, and my students know that if they see a test, not from us per se, but if they see a test and it says it's an African-American male with anemia, they'll just forget all the rest and just check off sickle cell, right? And because medicine in a lot of ways, like everything else, when you have problem solving, you use heuristics. And those mental shortcuts will help you make those quick decisions in problem solving. Well, medicine is taking those heuristics and embedded them in the way we teach. And that's what happens in these cases.
And it becomes self-perpetuating, and only Black people get it.
And there's no context. And right, and I can tell you how many I've seen. I practiced in New York for a long time. I've seen white patients with sickle cell. I've seen Indian patients, Chinese patients with sickle cell. But if I don't think about it, I'm not gonna know. So you can't just let those shortcuts take over. So the other thing is that we only see them in pathology. We don't see healthy Black people. We don't see healthy people of color, right? So we need to have all these alternate ways of presenting cases. And then we want to minimize that shortcutness and realize that race is complex and show some of the complexity, add a context into it. Social, is it because when I was coming up, I used to ask all my professors, what is it about being Black that causes disease? And they were shocked that somebody would ask that, right? But like, it was just because you're Black, you got hypertension. It wasn't like, what is it? Is it about our behavior? And in those days, they would say it was genes because nobody knew what the genes were. Now we have the genes and we haven't figured out what the Black gene is, and we haven't figured out where the hypertension and how that relates to hypertension.
We know they're not the same thing, whatever they are.
So that is the idea of this, to help people put together cases, and as they're talking about stuff, how they can put together vignettes that these guidelines will represent.
And so you have links to both the article, and this is the article, and to the guidelines. You can look at a more complete thing, but we wanted to give you a concrete example here. So this is a question you might see on a clinical test. 35-year-old non-smoking Black female presents with chronic non-productive cough. Any clinicians in the audience, what are we talking about? Bingo. Sarcoidosis. Yeah, you don't even need to go farther, right? So another way of putting this is a 35-year-old female presents with non-productive cough increasing over the last 3 months. Is a non-smoker living in the Shaw neighborhood of DC, denies sick contact, travel outside of DC. Her chest X-ray reveals hyaluronopathy. Now, the hyaluronopathy was probably in the other case. That's the real clue. That's the physical clue. But what happens is, first of all, we haven't said what color she is. Oh, closer to my mouth. I keep turning the other way. We haven't said what color she was. We said she lived in the Shaw neighborhood, but we didn't say she lived in Southeast. Anybody know where Shaw is and what's happening there right now? What's happening? Gentrification, right? So that's kind of what's going on there. So she could be any color, and her chest X-ray does reveal the hyaluronopathy, so that gives you the thing. Now, there is absolutely a difference in the epidemiology of sarcoid. Blacks have in the U.S. have a much higher rate than whites in the U.S., but there's still 12 cases per 100,000 whites in the U.S. of sarcoid, so you don't want to miss that. So we're going to talk very quickly about some of the things that we do in our curriculum to try and deal with these topics, because you can't just like have, it's like if we gave our students a course on racism in medicine, it wouldn't work. But we do across the curriculum, we keep bringing it up in different ways. We start our curriculum with an exercise in cross-cultural communication, a simulation. Has nothing to do with race, but it does have to do with difference, and forces them to start thinking about the fact that because somebody behaves in a very different way doesn't mean that they're bad or wrong, and start to come up with some ways of going through that. We assign them books before they even come into the program. We want them to read. This year we used The Immortal Life of Henrietta Lacks, and we always use Seeing Patients by Augustus White.
Those books, Henrietta Lacks actually was right up the road in Baltimore. We use her cells. Medicine has appropriated her cell line to use for all kinds of studies. Her family, she was never compensated or actually told about it. And the book really goes through both the social history and the biography of her and her family and the dynamics that have happened. Seeing Patients is a book written by one of the top orthopedists in the United States, Augustus White III. And he grew up in Memphis. The first part of the book is an autobiography of his experience of life and also going through medicine. And then the second part of the book is he's at Harvard, and him at Harvard going down the hall talking to people about what causes these kind of unconscious biases that exist. So the students get to read those. It is a kind of a virtual narrative around issues, particularly around race, but also around bias and stereotyping.
Then we also, one of the major things that a clinical student needs to know how to do is to interpret information about a patient case and give it to someone else, either in an oral or written form. So we talk about where, we teach them, do not say 25-year-old Black female presents with blah, blah, blah. We teach them how to present a case so that the race is embedded in a way that's useful or helpful, usually in the social history. Sometimes that social history needs to be brought up earlier in the discussion for whatever reason, but that it's contextual and it doesn't just have race and have that be the key word. We also present Kleinman's explanatory model for working cross cultures and communication, and cross cultures can be anything. It would include like me talking to another white woman of the same age who maybe grew up in a different part of the country, because we need to make sure that our language is the same and we have the same understanding of what we're talking about. And we spend a lot of time talking about social determinants of health. The number one reason people die earlier than other people is poverty. You know, and embedded in poverty is all kinds of stuff. So we help kind of tick that apart.
We have a course called Health, Justice, and
Of
Society.
course.
And it's a 2-semester course. And we use that to talk about a lot of the social elements that relate to medicine and healthcare. And the other courses have a lot of work around the technicalities of medicine. But we use this course to kind of how do they relate to each other? So it allows for complex conversations. It is the kind of place where we have conversations around race, around social determinants of health, and so forth. So in that course, we use an article by Dr. Kamara Jones called Racism, the Theoretical Framework, A Gardener's Tale. And she uses a metaphor of a gardener having 2 boxes of plants of different, one of the red plants and one of the pink plants. And by using the metaphor, she shows 3 different levels of racism: institutional racism, racism interpersonally mediated, and then also racism that is internalized by those plants, which represent folks. And so it allows us to talk about the structural levels and the other levels. But we also decide to use this not just to talk about race. We use that and have the students apply the framework to other isms like sexism, heterosexualism, classism, ageism, so they can see how structures really help influence how people think.
And it allows them a moment to take the focus off race. You know, so the article is clearly focused on race, but then they can take that framework, apply it somewhere else, so they begin to internalize for themselves in a way that personalizes for them how that might work, and then be able to apply it back to race. We then take them into the implicit association test. If you don't know that, there's a link here. You can go and take this test yourself. But a lot of racism or bias, period, is unintentional, and it is subconscious. So it's embedded in us by our culture and by, you know, just what we've learned over a lifetime. And what this test does is allows people a way to see how that happens. Now, this is where you get a lot of pushback and a lot of resistance. So we don't just, initially we did, now we don't just throw the test at them. We've learned a lot. We give them some pre-work, which includes some reading about the test and how it works, and some videos, and we have given you those at the end, so you will have access to those. That we introduce it, and then what we do is we have them do one of the tests on race, and we choose one other one for them. This year was fat, skinny, I think, or gay, straight. We rotate. And then we allow them to choose one other one. There are like 20 different tests you can take. And the pre-work then frames it for them. And then in our classroom, they have some online discussion, which is a little less scary. Then we have an in-class discussion where we really bring up the issues and talk about then how this relates back to, bias in medicine, because there's a clear relationship between results of this test and discrimination, absolute real discrimination.
You've seen in patient care. The other thing is we have them do a reflection, and one reason we started doing the pre-work is because everybody just said the test was wrong, right? And so, because the problem with implicit bias is that you don't know you have it. And so if it doesn't match, and it's really about an implicit preference you have. It doesn't mean you're going to act on it. But if you see, remember I talked about those dimensions of race and racism. If you see it and it emotionally doesn't match where you morally think you are, then it's a dissonance and it's hard to accept. So the easiest thing to do is to discount the test itself. So we give them the information about the test before we actually give them the test, so they can, so they will test, it's evidence-based medicine. You decide that the test is actually valid, and then you look at the results. And so that's what we do. And it doesn't want to change.
It really doesn't. This, I don't know about. There we go. All right. So as I mentioned, in terms of the IAT, and certainly in other parts of this discussion, we do get pushback. And so how do you deal with that? And that's one of the things we need to think about very carefully, is being able ourselves to both give and receive critical feedback in a way that it's going to be heard by the student, by other faculty sometimes. You know, how do you manage these discussions? I mean, just think about the last time, if you're white, maybe that you heard a family member or colleague say something racist and you felt the need to call them on it, but how do you do that? Or if you're Black, and here, you know, it's like, how do you manage those conversations? And now think about it in a classroom, right? So one of the things that we talked about is the idea of, instead of calling somebody out for something, calling them in. So what this involves is restating the problem. All right, so I heard you say this, but maybe stating it a little differently than they said it. Assume that somebody was not, their intention wasn't bad. You know, so assume that they meant a more positive thing that maybe came out their mouths. And so, so use that as an opportunity to educate, explain why maybe your wording is a little better than their wording about this concept, describe why their wording was bad, and how it could harm others, and then relate it back to whatever the context was.
So as an example, if we're talking about health disparities, but we're talking about health disparities or social determinants of health, and somebody says, well, colored people are discriminated more, you know, when they go out for jobs. And so, okay, remember those buttons? I got that colored people button. And so, take a minute. So one of the first things to do is kind of just restate the statement. And I will say, like, okay, people of color are discriminated more in the job market. Okay, and then kind of come back to, okay, like, I assume that's what you meant. You know, it's the wording, and then go into a conversation about the history of colored people as a use of word. It comes from the Jim Crow era, and it was used derogatorily primarily for African Americans, but not limited to Mexicans, everybody. Colored people was a negative term. And it's one of those terms that people of color, when they hear it, they feel it. And you may not know it because you don't know the history, but I'm using this as an opportunity to kind of explain that process and then go back into how this, you know, how this word might be experienced by other people in the class or other people, and then get back to relating it back to the class. The other thing that we do is that we usually take a minute and ask if it's, maybe that one's a place where I could use the words and example, but we ask the students themselves, you know, before we answer, you know, does anybody want to make a comment about that? And usually someone in the class itself, the answer comes from them. Most of the time, we don't have to do anything. And that's what we find is if we give us enough space for it, that will happen.
And that actually is heard much better than it's heard from us. So this is your assignment. Student in your class states the following in the context of the discussion of health disparities among people of Latin American heritage. Big part of it is because they haven't learned to speak English.
Take a moment. You can talk with each other, restate the problem, assuming that there's a learning opportunity here, and then, you know, explore the misconception.
If you see a misconception.
Right. You may not. Easier for other.
Very, like, not very wide.
Okay, do people have some ideas? And folks online, if you use the raise hand button, we'll get that. Does anybody have a good response here? Does anybody have any response here? Posiblemente no hablen inglés.
Okay.
Okay, somebody give it a try. How might you respond to this in your classroom?
I might say what I'm hearing is that there is a breakdown in the communication because perhaps they don't speak English as well as the provider.
One way is to restate the problem as a communication problem. Okay. Other ideas? Yeah. Well, before you get the question, let's
We want an answer first.
let's see if we can get we'd like to just hear like there's more than one way to do this, so
Yeah,
don't feel like
don't
it's
feel
not
like
the
you
right
got the
one.
wrong way.
Right. Is that what everybody? Oh, we have one from online.
Hi. Can you hear me?
Oh,
Aaron.
yes.
Go ahead, Aaron.
So I hear you saying that a big part of the problem is that they haven't learned to speak English. And I'm wondering, as you say that, who specifically is they? How are we sure of what they have or have not learned? And how would speaking English make the situation less disparate? And can we consider reasons why a person might not have learned English? Or perhaps if the provider could learn to speak Spanish better, could that address the problem as well? And I think the harm is just saying they sort of as a blanket for a whole group of human beings and assuming that, you know, they have all learned or not learned something. You know, it casts a whole group of people, you know, with a really wide net. How am I doing?
So that was helpful, Aaron. Thank you. So thing one is English proficiency in rising among Latinos. As this is pulled from a fairly recent article. So obviously, the assumption that somebody of Latin American heritage does not speak English is bogus. But so how might you frame that in the context of this? As well, so first to call in, so what I hear you saying is that language problems might be part of the difficulty creating health disparities, that communication between patient and provider is not what it could be. However, there is a misconception in that at least half of the people who are immigrants from countries of Latin American heritage do speak English quite well. And also there are some guidelines in place in the United States requiring that we have interpreters available for those who do not. I would assume that language is not the main barrier because it should not be, at least according to our law. That said.
And one other piece is that, you know, this information, which says like over 60% of Latinos or Latinx across the country, does not assume that they're all immigrants.
Right.
Which is another embedded part of this.
Yeah.
There are Latinos who've been here before most of us because Texas was once Mexico.
Right. I mean, there are names like San Francisco and Los Angeles that kind of indicate that maybe folks have been around here for a minute. You know, so that's the kind of thing. And we know we threw something that was totally out of your field at you, obviously. And when you're teaching something that you know, you're going to be talking about issues where you know what the stuff is, but just something to be aware of. what can come up in the context that you're thinking about.
And then the other thing is there's ways to, I think he honed in on the word they. So that even if you don't know what the numbers are, the honing in on when we say they, he turned it and asked the question is, who are the they that you're referring to, just for clarification.
Yeah.
But the other part is they is really a way of clumping and stereotyping
people.
and putting everybody in the same box.
So
And then
the,
you can come back the next time and give the right information. Like here's data.
yes, exactly. So I think we're about out of time. But just to summarize, there are some challenges. You will experience conflict, silence, and ambivalence. And I hope we've given you a few strategies to begin to think about how to address that. We can utilize the guidelines when we're teaching, at least in clinical cases. But even if you're outside the clinical realm, think about how that might apply to stereotypes that are embedded in whatever you're teaching. I mean, because this can occur across the board. And then coming back to the idea of anti-racism, that if you're not addressing race in your class, should you be? And if you should be, how can you do it in a way that begins to undo just the little piece of whatever you can undo in that moment in your context? Because we all have that responsibility, not just when you come to a session like this, but every day, all the time. It's got to be something that's front and center. Because if you don't think of it, it's perpetuated. Questions?
Somebody had a question. I know it was at the example.